tries for the mom to realize that no, the baby is not getting milk. So we'll look at the next picture and you'll realize what I'm trying to say. So here's the breast assessment. And this I had to explain to the midwife as well, that why we are using this position, because the nipples in her case were pointing way down and in towards each other. So can you imagine, the baby has to be so low under the breast for them to latch. And in this case, it was a 37-week baby. She had markers for insulin resistance. She had extra nipples on both sides. And this picture I just drew on my phone and sent it to the midwife to explain to her why the baby wasn't transferring. So she had to do a lot of herbal support for her milk to kind of increase in volume. And then she went on to breastfeed the baby. So let's play the video, Kavya. Thank you.
Buddy. Yeah. So go to the side and then walk your hand all the way towards your armpit on the breast tissue. Here, lower towards the baby's face. Nice. And play the piano. There's the eyes opening. Do you see? Yeah. I'm trying to hear it now. No.
So in this case, because she had a history of sexual abuse, it was very, very important that I had to back up on my hands-on skills, even though I knew how to help her hands-on, to get her to use her own hands on her body, because we have to be mindful and sensitive to the people and the clients that we work with. And she was able to latch the baby, feed the baby, and eventually they ended up feeding in whatever position they wanted to. But it took a lot of coaching and training and a lot of trust building in herself to get her to a place where she could do it. So just understanding that when we are trying to teach them new positions from what they expect to use, we have to remember that we are in this with them and we are constantly listening to what she thinks is happening and where we want the hands to be placed instead of just going in and helping them with our own hands. Okay. Now, this mom also had a history of ADHD, which I forgot to tell you. So, what I want you to think about is when you work with clients who have ADHD, how do you create a care plan for them uh, if they're struggling with ADHD? So, if you don't know what ADHD is, it is attention deficit hyperactivity disorder. It's also called ADD. And a lot of neurodiverse people also have focus concentration issues, and we are working with all of these families as parents, and some of the features of ADD ADHD are distractibility and hyperfocus. So you know what we need to remember is that it may be harder for them to respond to the baby's cues or read the baby's cues, and it can sometimes make them preoccupied, with all the things that they have to do. So for this mom, we had to take a very low tech approach to organizing how many feeds the baby needed and what kind of supplementation we wanted to do. So what we did was we just, I had a book with me, notebook with me, and I just tore some sheets out and made it very simple for her to do a little check mark every time the baby went, had a wet diaper, had a dirty diaper. And yes, there are many, many apps, and I would love for you to share them here with each other. That what did you do? What do you know of any technologies? Do you know of any apps? Do you know of any journals that you can suggest to your clients with ADHD? And if you ever wonder why people struggle with um, following instructions, take a step back and don't think that they are not being compliant. It may be that they are having a hard time following it because of ADHD or something like that, right? So a lot of women have undiagnosed ADHD. And what we want to remember is that, you know, most of the symptoms of ADHD or all of the symptoms of ADHD can happen to everyone to some degree. But we have to remember that these moms or these parents who are struggling and have a diagnosis of ADHD or not, they are struggling for a reason, and we have to find help for them, whether it is finding a therapist, finding a doctor who can help them with therapy or medicine if they are struggling with it. Eating and making food is very hard, which can interrupt. If you don't get enough calories in, it's going to interrupt what? Your brain to think properly. And that is hard when you're shouting out or saying instructions or telling them in the calmest way that this is how you should be tracking such and such. But, you know, there is a lot of other factors at play, and being aware of, how much information we are giving them. Is it creating a sensory overload for this client? Or if too much information is going down the brain where they are kind of muting most of it. So understanding that this can cause sometimes anxiety, anger issues, and these moms, if we are expecting them to sit for long periods of time, which when they're breastfeeding, a lot of moms are sitting for long periods of time. For a mom with ADHD, it can be excruciating to sit for long periods of time. So they are scrolling on their phone sometimes to keep their brains occupied. So yes, breastfeeding can be very boring, but at the same time, for a mom who has ADD, who has ADHD, um, it's going to be very hard for her to sit and breastfeed for 30, 40 minutes. And if this baby is not transferring enough milk, how do we create a care plan for supplementing? Whether it's supplementing at the breast, are they able to handle that plan? Are we, when we give them a supplemental nursing tube, are they able to manage the supplemental nursing tube without a support from their partners if their partners are unavailable, work night shift? So these are the things that we have to think about, like how do we create regulation within the dysregulation? um, let's go to the next slide. So in the next two videos, you will notice that I was instructing this mom on positioning, and I was trying to record a video on her phone so that she could share it with her spouse, and she could watch it herself when I was not there. So one of the things we can do is um, do videos on our clients' phones so that they remember how to, you know, use their own bodies properly to manage an overactive milk ejection response, lots of milk when the milk comes in on day 3, day 4, day 5. And you will notice that what I'm telling her versus what her body is telling us in the video is very different. So let's play the video, Kavya.
Here, I'm going to record this just so you can hear you too. You can um, see what I'm seeing from my perspective. Okay. Is I would bring your left shoulder down more, and then bring your right elbow. Yes, and relax. There you go. And then bring your left arm some more around him without lifting his bottom up. See how your hand goes on his bottom? Yeah. So you don't need to do this. You just need to kind of make it a little. Yeah. Yes, yes. Okay. Yes, because that's what opens up that. Okay. Yeah. Yeah. There he goes. So even with the fast flow, he is able to manage it. Okay. So scoot forward and lean back way, way more. Yeah, there you go. Nicely done. So on the left side, we're going to use this position. Okay. Because he's able to manage the flow better in this position. On the right, we can do the football, but he can be like in a reclining chair in front of you, and you can be reclining back. And when I got him in the football position, it was okay? That was okay. Yeah, that was perfect, yeah. How did you feel? You felt like it was okay? That was more comfortable than with just the recline. Going up. Yeah.
Let's go to the next video, Kavya.
Yeah. And in the mornings, you can just put like a little rolled up burp cloth on the left side if it feels like, oh yeah, it's so full that you won't be able to handle it at all.
Okay.
In terms of flow, that will also give him some support in the front. Yeah. There you go. And as he kind of wiggles his way to kind of slowing down or latching deeper, try not to bring your shoulder up, so it went up slowly. So we're gonna bring it down slowly. Yeah. Anytime you feel like, oh yeah, I feel like my grasp on my baby is loose, just lean into that blanket with your left elbow. If you lean into that blanket, the thing is, you will not bring your shoulder up high. Does that make sense?
Mm-hmm. All right, let's go to the next slide. So in her case, this mom's case, she had, if you look at her face, her body language, she has depression, she has severe anxiety, and what she was focused on was her baby would refuse the breast if there was too much milk. That was her focus, and that was part of the reason, because partly it was because her first baby started refusing the breast after 6 weeks, and she tried a lot to get the baby back to the breast, and he did not. So there was some amount of PTSD from that, and understanding that these moms who have their first experience of nursing their baby as difficult or not meeting what they had thought what breastfeeding would be like, we have to remember that they tend to ruminate. And ruminating means constantly having these repetitive thoughts of what if my overactive milk flow is going to prevent the baby from feeding, or if they are going to refuse the breast, or they will have a breast aversion. So these are the things that you all will come across as lactation professionals, and reminding these mothers that they can get through it, and sometimes providing them more support and finding them the support, right? So with her first one, she did not have any medication or therapy support, and she did not deal with it very well. This time around, before I even went into her home and she made the intake, she filled out the intake form, she told me that she was on an antidepressant. So that made a big difference in how she was perceiving things. Let's go to the next slide. So in this case, this mom had the chief complaint was baby is crying a lot, and she had a hard time comforting. This was her first baby. It was day 10, and baby was very fussy, and they try to burp him, and sometimes he will um, like keep himself from burping. That's what their description was. And then not fall asleep if they tried to burp him, or he would wake up again. And at day 10, when she called me and I went in, the baby had lost weight. And what they told me was that, um, they had started using the pacifier against what their midwife had advised them, uh, because that was the only way the baby would stay calm. So this was a home birth baby, and on day 1, the baby did not latch. Day 2, the midwife gave them a nipple shield so that she could latch the baby. And day 7 to 8, the baby started becoming more and more fussy at the breast. So the weight dropped over the period of 10 days. So when we are talking to parents about, pacifier use, it's very easy for us to come and say, no, don't use the pacifier. So instead of that, how can we educate them on what is a better way to teach these parents that pacifier use can be done, but not in the presence of weight loss, and inviting a sense of curiosity on asking them a question like, I wonder, and I'm curious, what you think that happened in the past 10 days. Because once they see the weight, they are able to see that something was bugging the baby. And what was bugging was not that the baby was fussy or does not want to sleep. It was the fact that the baby wasn't getting enough calories, right? So I just want to make sure that when we are working with babies and parents, we have to be again mindful of our language. And if latching remains difficult, um, tell them that it may be because the baby is not getting enough milk. Demonstrate the positionings and give them a supplementation plan that is simple to follow. And whether they use bottle or whether they use a supplemental tube, it's okay. But when we are suggesting things like finger feeding with a syringe, and the baby is taking about 2 ounces, and we give them like a 5 milliliter syringe, we have to be mindful that how many 5 milliliter syringe does it take for them to fill up in the middle of the night to feed the baby, right? So just understanding that every single dyad you're working with is a case study for yourself, and we are evolving as providers when we are working with these parents, and we all make mistakes. All right. The next one, you'll see a baby who is nursing in side lying. And this mom had a pretty bad perineal and labial tear. She had a tailbone fracture, and she had nursed her first baby in the cross cradle position. So it was completely new to her to feed this baby in a side lying position. Um, and this baby also had a lingual frenulum that was restricted. And so what we did was we tried to create compensations for the mom for the baby, where she kind of did the under the chin support and also opened the baby's chin a little more so that the nipple could go in deeper into the roof of the baby's mouth. And this mom was not interested in releasing the lingual frenulum, so we just went on and did side lying, and she used these compensations for a little bit until she didn't need to use them.
How is the pain for you?
It's pretty good.
Good.
All right. So, um, finding ways to support clients who have these challenges is very, very important. And in her case, she probably used the compensations for about 4.5 weeks. She didn't have to always hold the baby's chin, but she definitely had to hold under the chin because of the lingual frenulum being restricted. This is a mom who had a second baby. Baby was tongue tied, and her milk had just come in, and she was in excruciating pain. And you will see in the video what we did there. Let's play the video, Kavya.
I like that. So the towel was like, it's like a breast lift, basically.
Yeah, because her breast is so full
Yeah.
and he has a tie,
Uh-huh.
so it's harder for his chin to carry the weight of the breast on his chin if you,
Yes. That makes sense.
and then I would even lean back some more if you can. One
Okay.
pillow off.
Oh. Whoa.
So lean back. That's okay. How you doing?
Oh.
Feeling good?
Yeah. Oh. Can I sleep now?
Yes, totally. then
So this mom had the habit of just hunching over the baby to feed the baby. So what we did was and she didn't want to do the full laid back position. She had a planned C-section due to some other health issues she had. So um, the rolled up burp cloth under the breast helped her and the baby, and she could have a pain-free feeding. In this video, I'm just showing the mom how to keep the baby awake at the breast. You can also see the rolled up burp cloth. But what we have to remember is instead of teaching parents to use cold washcloths to wake their baby up, we have to teach them the power they have in their own hands that that can be used to wake the baby up. So we are teaching them a deliberate affective touch to arouse the baby, and so any amount of maternal touch is better than a washcloth, a cold washcloth. So we're gonna play this one.
so you can rub his head from the forehead towards his back. There he goes. Come on. There he goes. Sorry to wake you up, but I gotta wake you up. There he goes.
Wow, the light doesn't even bother him.
No, usually doesn't when they're eating. Yeah.
All right. So understanding that our job as lactation professionals is not just helping them with the latch and positioning, but trying to find ways for them to connect with their babies. And touch is the fastest way for them to connect to the baby, right? And also touch besides the latching and positioning touch. And we have to fill up these big postpartum precipices that our clients fall through sometimes, and it's hard. But understanding that, let's not wake them up in in a rude way. Let's go to the next slide. Um, all right, let's play the video here. Oh, you're going back. Next one here. Okay, so in this case, this mom had, let's play the video first and you tell me what you see first, actually, in this case.
Yeah, I just wanna use this too. Now, as you feel the breast soften under your index finger, you can go a little higher. Yeah, there we go. And you can use the middle finger to slowly open that chin up. Yeah, beautiful, beautiful. Look at that. Good swallowing.
So in this case, the mom was really wanting to feed the baby in this position, but this baby had a high palate, a recessed chin, and she had really hard time keeping that nipple in her mouth. And if she did keep the nipple in her mouth, she was not able to transfer a lot of milk. So, um, what worked for the dyad was not what I asked her to do initially. So, I want you to understand that all of us have suggested different things to different parents, but there are times when we feel like I'm not doing something right, or I am having a harder time um, getting through to this client. um, we have to remember that they are um, adopting these adverse postures, ergonomically adverse for them, um, to basically get the baby to eat. So within that, how do we create a place where the baby gets more milk? So for her, this was the position that worked best for her to hold her baby. And what we did was to keep her from not losing the latch and keep getting more milk. I taught the mom the finger placement on her breast tissue. Um, and eventually, you could see in the slide before this one that she, if you look at the picture, uh, Kavya, can you go back to this slide where the picture where she actually was able to do laid back nursing? So we have to remember that each dyad is going to teach us something, and it keeps us humble, and we need to learn from them. All right, let's go to the next slide. So this is a little quiz for you guys. What would you suggest if this was a virtual